Detection and treatment considerations for multiple synchronous unilateral breast primary tumors of different types, case series and literature review. Patient presentation with multiple ipsilateral malignant breast masses brings certain challenges to the entire care team for the detection and identification of the tumors through treatment planning and treatment process, perhaps even extending into post-treatment survivorship and surveillance. For this presentation, I will briefly focus on review of existing knowledge on multiple ipsilateral synchronous breast cancers based on limited literature review. Then I will provide some background on the composition of our care team and our current practices for successful coordination of care and patient navigation in general. I will follow with the discussion of 3 separate cases encountered in my practice over a 2-year period from 2021 to 2023. In conclusion, I will highlight a few specific details of each case that prompted the team and me personally to approach things slightly differently from the usual practice. Synchronous breast cancers are defined as 2 distinct tumors diagnosed in the same patient within 3 to 6 months. Tumors diagnosed after 6 months cutoff are described as metachronous. It is difficult to establish the accurate incidence of synchronous unilateral breast cancers, especially in cases of tumors that are of different cancer subtypes and differ in their histopathologic presentation. The incidence of bilateral breast cancers appears to fall between 2 to 11% when synchronous and metachronous lesions are grouped together. The presence of multiple malignant breast tumors at the time of diagnosis has an even broader range of up to 70% when all detected tumor foci are considered. In most reviewed studies, the percentage of multifocal and multicentric cases within the total number of patients analyzed seems to be within 7 to 20% range. It would be reasonable to review synchronous ipsilateral breast malignancies as a subset of multifocal, multicentric disease, with term multifocal defined as masses present with one quadrant of the breast and multicentric describing masses within different quadrants. It should be noted the distance between tumor foci is occasionally used as the basis for distinguishing multifocal and multicentric disease. Widespread use of breast MRI facilitates the simultaneous detection of synchronous tumors when one mass is less apparent than the other. More frequent detection of multifocal, multicentric disease is attributed to use of MRI. Certain radiologic characteristics of the masses, as well as the patterns of contrast uptake and washout, may signal that the tumors differ histopathologically and prompt additional investigations. According to current guideline of American College of Pathologists, biomarker testing for additional foci of disease, ER, PR, and HER2 is recommended only if carcinomas show different morphologies and grades. Some studies challenge this approach by demonstrating that biomarker variation between 2 tumor foci is quite common. In 2019 study by Navali, 17% of reviewed cases showed discordant staining in 2 separate tumor foci by at least one biomarker. In majority of cases, failure to detect this difference would result in failure to consider appropriate adjuvant treatment. Similar concerns were raised in study by Ton and others that found pathological type, molecular subtype, and histological grade mismatch in 22.3% of cases. It has been demonstrated in literature that multifocal and multicentric disease carries worse prognosis in terms of local recurrence, recurrence-free survival, disease-specific survival, and overall survival. It is more likely to present with nodal involvement. Some studies suggest that current staging guidelines lead to understaging of tumors presenting with multiple foci. Only the size of large tumor foci is used for determination of the T component. When aggregate size of all tumor foci is considered and stage is assigned based on this aggregate, the outcomes are comparable to the unifocal malignancies of the similar stage. In other studies, when adjustment is made for factors associated with poor prognosis like African American race, larger size, nodal involvement, higher tumor grade, lymphovascular invasion, HER2-positive disease, and triple-negative disease. The outcomes are comparable between multifocal and multicentric and unifocal disease. These findings may suggest that cancers that present as multifocal multicentric disease are inherently of more aggressive behavior. This study by Neri and others noted negative impact of multifocality and multicentricity on prognosis, with observation that improvement of outcomes was observed in patients treated with anthracyclines, suggested that perhaps more aggressive approach to chemotherapy is needed for this kind of disease. For many years, the presence of multifocal multicentric disease precluded patients from being treated with breast-conserving therapy, making mastectomy the only option. This belief has been changed, and presentation with multifocal multicentric disease is no longer an absolute indication for mastectomy. Breast-conserving therapy can be safely considered in patients that meet criteria. The study of Hami and others, although focusing on bilateral synchronous cancers, brings up a thought-provoking point that when synchronous cancers of different histopathologic nature arise, both breasts have been affected by same germline genetics, reproductive life factors, and environmental exposures for many years. Yet simultaneously diagnosed bilateral malignant breast masses are not clonally related and represent two independent events. It is reasonable to think that in cases of ipsilateral multiple tumors of different pathologic and possibly different molecular subtypes as well, the development of two separate masses happens independently as well. Cyclope hypothesis by Goin and Todd offers reasonable explanations for development of two breast malignancies of different biology within the same breast. It suggests that certain embryologic events introduce mutations and genetic instability within a cell that will later become precursor for one of the breast lobes. With organism growth and development, all cells arising from that single precursor will carry on the mutation and accumulate additional mutations through the lifetime that will ultimately result in malignant transformation. Another lobe within the same breast may have been rendered more vulnerable to malignant transformation as well, but through a different original mutation, thus leading to malignant transformation through different pathway and resulting into a tumor with different pathologic characteristics from the first tumor. The care for a patient with breast cancer is best delivered in the setting of a multidisciplinary team. There is no requirement that members of a team should be part of the same practice or institution. If the channels of communications are well established and information and updates on patient care are regularly shared with each team member. In our practice, all patients with new cancer diagnosis are discussed during biweekly multidisciplinary conferences, tumor boards. The treatment plans are established, and any changes or needed revisions are promptly communicated to the rest of the team by a physician who is initiating the change. Radiologic images are accessible to all members via remote access and are reviewed together with reading radiologists. So, patient number 1, 48-year-old perimenopausal woman with no prior breast imaging. She presented with right breast distortion, contraction, and skin retraction at lower outer quadrant. Lymph nodes were clinically negative. Diagnostic imaging with mammogram and ultrasound revealed 2 right breast masses at 6 o'clock and 7 to 8 o'clock, and a suspicious left breast mass at 1 to 2 o'clock. Lymph nodes were radiologically negative. The mass at 6 o'clock was apparent on mammogram, and ultrasound was measuring 1 centimeter with non-parallel orientation, angular margins, and internal vascularity. The 7 to 8 o'clock mass appeared as architectural distortion on mammogram, and ultrasound measured about 2 centimeters, had irregular and spiculated appearance with posterior acoustic shadowing. Left breast mass appeared as focal asymmetry with microcalcifications on mammogram and was measuring 2.5 centimeters on ultrasound with irregular, microlobulated, and hypoechoic appearance. All 3 masses were biopsied. Six o'clock mass was mucinous invasive breast carcinoma, grade 1, Intermediate grade DCIS was present, no lymphovascular invasion, estrogen receptor positive, progesterone receptor positive, HER2 by IHC 1+, negative. Ki67 was 28%. 7 to 8 o'clock mass was invasive ductal carcinoma, grade 1, high-grade DCIS present, no LVI, ER positive, PR positive, HER2 by IHC 2+, by FISH negative. Ki67, 17%. Left breast mass demonstrated proliferative changes without atypia. MammaPrint blueprint genomic testing was performed on both malignant masses, and both masses appeared to be of luminal A type. Breast MRI was obtained, and aggregate size of both right breast masses appeared to be more than 6 centimeters with some indeterminate pectoralis muscle enhancement. Based on that information, additional staging scans were obtained, revealing teratoma of the right ovary. No concerns for metastasis. Hereditary cancer genetic panel was negative for clinically significant mutations. Right breast mastectomy was performed based on tubular shape of the breast and significant tissue distortion laterally. Patient had immediate reconstruction with expander. Sentinel lymph node biopsy revealed 5 negative lymph nodes. On final pathology examination of surgical specimen, 6 o'clock mass was reclassified as encysted papillary carcinoma. 2 centimeters of non-affected tissue was noted between 7 to 8 o'clock and 6 o'clock tumors. Final stage, MPT2 and 0MX. Oncotype DX testing was obtained for invasive ductal carcinoma and was consistent with MammaPrint blueprint results with low recurrence score of 7 and no chemotherapy benefit. No radiation therapy was indicated. Patient started on adjuvant endocrine therapy with tamoxifen. 6 months post-surgery, she had left breast mastopexy and was noted to have atypical ductal hyperplasia within the excised left breast parenchyma. After extensive discussion, she opted for left breast prophylactic mastectomy with implant reconstruction. Right breast expander was replaced with implant at that time too. Patient number 2, 57-year-old postmenopausal woman, natural menopause at the age of 53. Known high-risk patient with IBIS score 26.4% due to family history of breast cancer, personal history of dense breast tissue, and proliferative breast changes. Genetic testing for hereditary cancer syndrome was negative. New irregular opacity in the medial left breast noted on annual screening mammogram. The opacity persisted on spot compression, and ultrasound presented as 0.8 centimeter antiparallel focus with posterior shadowing. Biopsy revealed invasive mammary carcinoma with lobular features. Grade 1, no DCIS, no LCIS, or lymphovascular invasion. Estrogen receptor positive, progesterone receptor positive, HER2 negative. Ki67, 5%. Lymph nodes were clinically and radiographically negative. Breast MRI demonstrated 8.2 millimeter moderately enhancing mass at the medial left breast and some stable benign appearing foci of enhancement in the right breast that was followed previously. No suspicious lymph nodes. Patient had left partial mastectomy and left sentinel lymph node biopsy. Final pathology report described invasive lobular carcinoma, multifocal, with larger single dimension of 1.7 centimeters, positive for perineural invasion, no LVI, 1 node negative for malignancy. Incidentally, several foci of invasive ductal carcinoma of micropapillary type, grade 2, largest single dimension 0.5 centimeters with extensive LVI was noted. ER positive, PR positive, HER2, 0 by IHC, negative. Ki67, 14%. The margin was positive for micropapillary carcinoma. Subsequently, patient had bilateral mastectomy 2 months later with final pathology demonstrating multiple lymphangitic foci of micropapillary carcinoma throughout central and upper outer breast. No residual lobular carcinoma. Focal areas of atypical ductal and lobular hypoplasia were noted within the breast parenchyma. Lymph node mapping was repeated. An additional node was found in the left axilla. It contained isolated tumor cell clusters. Final stage was as follows. Right breast with atypical ductal and lobar hypoplasia and radial scar, no malignancy. Patient received adjuvant chemotherapy with 4 cycles of taxotere and cyclophosphamide. She started adjuvant radiation therapy to the chest wall and left axilla. She will receive adjuvant endocrine therapy with aromatase inhibitor. Finally, patient number 3, 48-year-old postmenopausal woman, status post-hysterectomy at the age of 43 for benign reasons. Presented to primary care doctor with left breast changes, nipple retraction and contraction. Initial mammogram with limited views and was indeterminate. Architectural distortion was noted. Follow-up ultrasound demonstrated 0.7 centimeter cyst versus intraparenchymal lymph node in the lateral aspect of the left breast. Breast MRI revealed irregular 1.8 centimeter left breast mass at 2 o'clock position, resulting in nipple retraction. Satellite lesion measuring 8 millimeters was noted medial to central to the 2 o'clock lesion and was located at 12 o'clock. 2 thickened axillary nodes were noted. Second look ultrasound was performed and correlate for both MRI masses were found. 2 o'clock mass measured 1.5 millimeters. It was irregularly shaped with angular margins and posterior shadowing. 12 o'clock mass measured 0.6 centimeters. Indistinct margins were noted. Both masses appeared to be slightly taller rather than wide. 2 axillary nodes with thickened cortices were noted. Both masses and one of the nodes were biopsied. Mass at 2 o'clock was determined to be invasive ductal carcinoma, grade 2, no DCIS, no LCIS, no LVI, ER, PR positive, HER2 negative, Ki67, 15%. Mass at 12 o'clock was determined to be invasive ductal carcinoma grade 2, no DCIS, no LCIS, no LVI, ER positive, PR positive, HER2 was equivocal by immunohistochemistry. By FISH, it turned out to be positive. Ki67 was 50 to 20%. Given discrepancy between 2 tumor foci, in terms of HER2 positivity, lymph node was investigated for biomarkers as well and was ER positive, PR positive, HER2 by FISH positive. Staging scans revealed slightly prominent subpectoral lymph nodes and no other findings suspicious for metastatic disease. Genetic testing for hereditary cancer syndrome was negative. Patient started neoadjuvant therapy and anti-HER2 therapy with taxotere, carboplatin, trastuzumab, and pertuzumab. After completion of neoadjuvant chemotherapy and planned portion of anti-HER2 therapy, she was re-evaluated with post-treatment breast MRI, demonstrating only partial response with persistent abnormal appearance of axillary lymph nodes. She had modified radical mastectomy and final pathology for surgical specimen demonstrated residual invasive ductal carcinoma. Invasive carcinoma was seen on the blocks of tissue between 2 previously identified masses at 12 o'clock and 2 o'clock. Furthermore, foci of carcinoma were seen in upper inner, lower inner, and outer quadrants, the areas without grossly identifiable lesions prior to mastectomy. 5 out of 8 lymph nodes were positive for metastasis, with 1 node demonstrating extranodal extension. Final stage was as described. Patient had immediate left breast reconstruction with tissue expander. Patient is set to proceed with adjuvant radiation to the chest wall and axilla and posterior anti-HER2 therapy followed by endocrine therapy. There are a few points that are worth making after reviewing these cases. All 3 patients underwent mastectomy for surgical treatment. It should be noted, though, that in each case, the reasoning for mastectomy was made based on considerations other than diagnosis of multifocal multicentered disease. For patient number 1, it was mainly concern for possibility of good aesthetic result with combination of tubular breast shape and significant asymmetric contraction of lateral breast extending to the central breast. For patient number 2, it was the concern for inability to fully assess the full extent of micropapillary carcinoma within the breast tissue. For patient number 3, it was the overall contraction and architectural distortion of the left breast, even in the quadrants without obvious masses. Although it presented as a case of multifocal multicentric disease of different molecular subtypes, it appears that patient number 3 has a contiguous carcinoma that exhibits tumor heterogeneity. This was not known until after mastectomy, thus certain clinical decisions were made based on the premise that there were 2 distinctly different masses of dissimilar molecular subtype. In every case, the treatment decisions were guided by determination of which foci will be more likely to influence the outcome. For case number 1, additional genomic testing with Oncotype DX was obtained for the invasive ductal carcinoma foci. Since encysted papillary carcinoma usually behaves as in situ malignancy. For case number 2, the decision to proceed with adjuvant chemotherapy and radiation was largely based on the evidence that micropapillary carcinoma tends to invade lymphovascular spaces early on and tends to metastasize early. In case number 3, once HER2 discrepancy was detected, additional pathologic testing was requested on biopsied lymph node, and anti-HER2 therapy with trastuzumab and pertuzumab was recommended. None of these patients had any genetic mutations resulting in increased risk of developing cancer, although patient number 2 had quite extensive family history of reproductive cancers. In 2 out of 3 patients, atypical changes of the breast tissue were identified in contralateral breast as well. Contralateral breast tissue was not evaluated in patient number 3. This raises a question of possibility of entire breast tissue field cancerization, if not by yet unknown germline mutation, then by early somatic mutations affecting multiple breast lobes. Perhaps purely coincidental, but all 3 patients were noted to have dense breast. Each patient was evaluated by breast MRI prior to surgery, and in my practice, breast MRI continues to be the tool that facilitates surgical decision-making and helps with surgical planning. This is the list of my references. And this is the contact information for any questions. Thank you for your attention. Have a wonderful day.